All right, nice case of renal vein thrombosis. Of course, you always worry that this is secondary to a renal neoplasm, but certainly bland renal vein thrombosis does occur. It's a lot like portal venous thrombosis in that it often follows on a relatively benign illness where the patient allows themselves to get dehydrated and thus have a predisposition to in situ thrombosis. So this, you can see the renal enlargement and stranding. It's clearly bigger, and the nephrogram is also delayed compared to that other side. You've got a very nice large filling defect right there in the left, or sorry, the right renal vein. You can see here it's kind of poking its nose into the IVC. There again is the renal enlargement and the filling defect in the right renal vein. You see how it's got a little nubbin sticking up there into the IVC. And certainly these can embolize just like any venous clot. They don't just stay there. I've seen any number of cases of renal vein thrombosis actually presenting with pulmonary embolism. So there's that filling defect, and you can see very nicely that extension into the IVC. Right there. All right, let's look on the coronal, which really lays it out nicely. A lot of stranding, massive enlargement of that kidney, and then a filling defect pretty much running the whole extent of that right renal vein. All right, so that is bland renal vein thrombosis. All right, this one is non-contrast, so possibly not as fun, but it's important to realize you can see venous thrombosis on a non-contrast scan. You've got enlargement of the left kidney with clear perinephric stranding. It looks like the non-contrast version of the case we just saw with renal enlargement and perinephric stranding. And then look at the enlargement and increased density of the left renal vein. And the cool thing about this one is, of course, on the left side, the left ovarian or gonadal vein is going to be dumping into the left renal vein. And you can see it here also significantly hyperdense, and the stranding related to this venous occlusion extends all the way down the left flank. So there goes that renal vein, and then you can see coming right off it and getting all tortuous and hyperdense there is the left ovarian vein. So you will see these in conjunction when you clot your left renal vein. It frequently will run down the gonadal vein on that side. On ovarian vein thrombosis, be particularly vigilant and pick out those ovarian veins in postpartum patients. There's a tendency to form ovarian vein thrombosis in the postpartum phase. So something to just always keep in mind. I check the ovarian veins on every postpartum patient I get. All right, so that's renal and ovarian vein thrombosis. This next one is a new one, and we actually don't know what the renal pathology was here. So there is a filling defect in the left renal vein, and that will be more apparent on the cine views. But there's also increased density in the collecting system itself, right there. And that is actually running down the left ureter into the bladder. So there is a significant amount of increased density in the bladder, consistent with hematuria. So this patient had something that was bleeding in the collecting system, and ultimately clotting in that region extended into the renal vein. Certainly it could have gone the other way. Perhaps the renal vein thrombosed first and then caused something else to bleed and dump into the collecting system. I don't believe that's the case here. The left renal vein is not enlarged. The thrombus in it does not appear occlusive. And so I think that probably this began with hematuria and clot extended, non-occlusive clot extended into the left renal vein. Right, on the coronals, you can really appreciate the filling defect there in the even the more proximal portion of the left renal vein. And again, there is the hematuria. So there is a lesion in there dumping blood into the collecting system. And obviously, to me, that is the primary source of bleeding because the clot in the bladder is so impressive. So there's the bladder clot, and here is that incompletely obstructing left renal vein thrombus and the hematuria. So look at that one more time. The radiologist reading this said suspected an AVF. I don't believe, and this is actually a pretty new case, so I'm waiting to call on the results, but I don't believe we're going to hear that this was an AVF. And with AVFs, the vein should be significantly enlarged, and they don't necessarily predispose to venous clot. Usually they're very high flow. And we'll see that coming up. Aha! So here is an actual renal AVF. So you can see this results in enlargement of all the involved vessels, right? The veins enlarge because they're seeing arterial pressure flow, and the artery will eventually enlarge due to the sumping effect of the enlarged vein. So ultimately, you will get enlarged arteries and veins feeding these renal AVFs. So this is actually the dilated renal artery, and then this is the renal vein. And look at the size of the IVC, which is receiving that arterial pressure inflow. Note also the hepatic venous retrograde opacification, which is pretty impressive. So that venous return is going up and down the IVC at pretty high pressure. You can see it extends below the level of the the right renal vein right there. See, the contrast is going retrograde down the IVC. It's also coming up the IVC and out retrograde into the hepatic veins. So that really gives you an idea of how increased the flow is in these situations. There are those hepatic veins. Then a huge tangle of renal artery, renal vein, giant dilated IVC. All right, so that is a renal arteriovenous fistula. This is one of the biggest renal artery aneurysms I've ever seen. And the thing that really helps you here, of course, it's contrast density. But depending on phase of contrast, and sometimes these things will thrombose or swirl, sometimes that can be a tricky call to make. But always look for that peripheral calcification. You can see that dot of peripheral calcification in a couple of places. That really tells you I'm looking at a vascular lesion. So it can be very helpful. And there's a great deal of perinephric fluid here, and there's actually even active extravasation here lower down. So there again is that contrast collection with peripheral calcifications telling you this is a vascular lesion. And then adjacent to it, there's the extravasation at ill-defined wispy density that is leaking contrast. So this one hasn't necessarily sumped as much blood as that AVF. It's not a high flow state necessarily. Obviously, the renal artery to that side is slightly enlarged and tortuous. Very nice view of that peripheral calcification. All right, so that is a giant renal artery aneurysm with rupture. Okay, this is one of my favorite cases that I use in my Jeopardy games from time to time. There are tiny little aneurysms here in the hepatic arteries. Then there is a perinephric hemorrhage that you'll appreciate better lower down. It's pretty extensive. So in the kidneys as well, there are little renal artery aneurysms. And when we look on the cine, you'll see these things blinking in and out. They're quite numerous. And then on the posterior aspect of that left kidney, you can see a perinephric fluid collection with layering density, telling you that that is in fact extravasation and a hematoma. So the assumption is one of these tiny aneurysms ruptured, and you can see there are a bunch of them in the liver and in both kidneys. You can see these little white circles blinking in and out as we page through there. So the assumption is one of them blew and gave this patient a perinephric hematoma. You can see that layering density very nicely there. So multiple renal artery aneurysms and hepatic artery aneurysms, that makes you think of the inflammatory vascularities. It should also make you think of IV drug abuse and things like that. So this patient, though, happens to have this tiny little cavity in the imaged portions of the lung bases. So that lets you just seal the deal. This isn't polyarteritis nodosum or Tuberous, right? This is Wegener's or granulomatosis with polyangiitis, because they have the tendency to form cavitary lesions in their lungs. And there was just that. All we had were the lung bases, but fortunately one little cavity appeared there, and we were able to make the definitive diagnosis. So that's granulomatosis with polyangiitis, which to me is Wegener's granulomatosis. All right, since we're doing renal hemorrhage, you can see bilateral massive enlargement of both kidneys with these fat density masses. And then, of course, there is a great deal of perinephric density surrounding that left kidney. So this is most likely a patient with tuberous sclerosis. Certainly women without tuberous sclerosis, commonly women in middle age 40s and 50s, will develop AMLs, and they certainly can be multiple and bilateral. But when you see them to this extent, I think you can pretty safely assume this is going to be a case of tuberous sclerosis. So there is near complete replacement of both kidneys with these fatty masses. And you can see inferiorly here a giant collection of perinephric density with layering density, again, suggestive of a subacute hematoma. So pretty impressive. Just try and pick out some normal renal parenchyma. You do see a few rounded soft tissue densities, and of course AMLs can have a soft tissue component, and it's quite variable as to how much soft tissue and fat they'll demonstrate. Pretty impressive. And there is that large left perinephric hematoma. Inferiorly, be sure you note that layering, that density level there, which really helps tell you that's settling blood products. All right, so that is bilateral angiomyolipomas in a patient with tuberous sclerosis and acute presentation with hemorrhage. So you'll see a lot of polycystic kidneys, but you don't see them hemorrhage all that often. Certainly they can hemorrhage, they can be super infected, and ultimately there is no significant increase in renal cell carcinomas or other tumors with polycystic kidney. That's a little bit under debate, but if there is a predisposition, it is not great. But I'll tell you one thing, these things do complicate the search for tumors, right? When you MR these, they can have blood products in all stages and be a bizarre mix of hyperintensity and hypointensity. So here you can see a great deal of density and perinephric stranding consistent with acute hemorrhage. And lower down, you can see the exact extent, and you can get a sense of what I was talking about too, right? Some of these cysts have hemorrhaged and will be hyperdense. So it makes the search for any coincident renal cell carcinoma very difficult. So that is impressive, near complete replacement of the kidneys with benign cysts. So let's look at this upper pole on the right kidney. And you can see that there's a lot of stranding and density there, consistent with hemorrhage. And obviously this patient doesn't have a lot of functioning renal parenchyma, so he's got a renal transplant there in the right lower quadrant. All right, so that is adult polycystic kidneys with acute hemorrhage.